Dr. Canton and Dr. Fernandez-Cruz. And we will move from research to daily healthcare. And let me introduce a little bit the roundtable. I don't know if I can go to the next slide. First, let me say that when we, yeah, thank you. We all feel that we've been working in serology of SARS-CoV-2 for years. But if we look at what we have really done, we started to report results, let's say, about March. So we've been working hard, but only for about 30 weeks. Working very hard and producing a lot of new. I am just receiving pop-ups continuously about audios and videos. So sorry, but I will try to follow on. Okay, so as I said, many medical teams all around the world have produced a lot of new evidence about the timeline of and the dynamics of the antibodies, have done a lot of research about the clinical indication of different antibody classes, and in this disease with new proposals of some of the antibodies that we are not using in other viral infections, like IgA or total antibody testing. We've been also able to produce a lot of evidence about how different are the results we receive from different commercial tests from different brands, and how we need to fine-tune them for our purpose in the daily healthcare, as I said. And at the end, we have a lot of evidence about the clinical outcomes and the clinical indication of these new tests in diagnostic, in follow-up of immune response, and follow-up of immune status. Let me just give you an example. If we move to the next, please. This chart is the first we adopted coming from Asia at the beginning of the pandemics in Spain, and I think in all over Europe at least, where we had the first idea of how was the dynamic of the viral load and the antibody dynamic also, when antibodies appear, when they disappear. It had a main purpose in diagnostics at the beginning, but it's true that it was used for many other things, like, for example, decisions about how long should be the quarantine, or when an isolated patient could go back to the workplace. If we move to the next one, please, we will see that in our data coming from the first thousands of patients we tested, things were, I would say, not completely different, but very, very different. And this chart has been confirmed by many other authors in the publication. So my first point about this new evidence is that the evidence we received was not exactly what we've confirmed later on, and that many decisions that are being made today have changed in terms of the data we are using to make that kind of decisions. And of course, all these decisions related to quarantines, isolation, viral loads, when to test, have changed a lot during these few weeks that we've been working with serology in the COVID-19. If we can go, please, to the next one. Just to end with this introduction, not only evidence has been generated by medical research teams all over the world and commercial companies, we have a lot of controversies on the table. So we need, and it's a real need that we are all facing, to redefine good cutoff of the commercial tests we are using in all the labs, and specifically in some specific countries. We still discuss which is the right selection of tests, and I am sure that today we will have some answers to some of these questions. We need to explain, and we've not done yet, what is the future of those patients we test, and in a few weeks antibody titers disappear completely, so they become negative, and we don't know exactly what to tell them in the daily practice. We need to explain better if what we are testing has any relationship and what kind of relationship with neutralizing antibodies. And beside these controversies, we need also to face future challenges, like how to combine with the study of cell-mediated immunity, what kind of indication, clinical indication we put on the table to test for neutralizing antibodies, and how we will support vaccines in the future, or production, or hyperimmune or convalescent plasma, and all that kind of future therapies that could need the support from our daily labs. So my introduction is, in very few weeks, we've been able to produce a lot of evidence that is really helpful, and we will see in the next presentations. We still have a lot of discussion and a lot of solutions to provide to our physicians and patients. And we, at the same time, need to think and make some research to support the future challenges that will appear in our labs in the next weeks. With this, I will propose to give the floor to the presenters. The first presenter, I think you can, is Dr. Benito Regueiro. He is professor in the University of Santiago de Compostela in Galicia. He is the head of the Department of Microbiology in the University Hospital of Vigo. And I'm sure he will be able to give us some insights and some answers on these evidence and controversies at least.
Well, it is my pleasure to participate in this meeting, and I wish to thank you organizers for their invitation. And I would like to go directly to the point. So please, the first slide. Well, second slide, sorry. I would like to stress the need of understanding, the second slide, please. I would like to stress the need of understanding the differences between analytical sensitivity and clinical sensitivity. The first, the analytical sensitivity ranks around 90%. That is needed as a regulatory conditions for FDA accreditation of CE marking of our tests. On the other hand, the clinical sensitivity of most of our current individual molecular and serological testing is only of 50 to 60, which implies the need of combining tests to reach, as was already published, of 98.6% of clinical sensitivity when you combine molecular and serological tests. In fact, when we perform testing, we have to face two initial constraints in our diagnostics. The first is the need of sample quality. For molecular, we are using nasal swabs or oropharyngeal swabs, and now saliva that help us in self-sampling. And of course, we use serum of cells in the case of serology and neutralization test. And the second constraint, and most importantly, is the need of coronavirus case interpretation. In fact, we don't produce just directly results, simple numeric results. We need clinical data, we need to know and understand PCR-CTs, and we need to understand how to provide a serology in order to give a right answer to our clinicians and give the three possible results that are positive, negative, or residual RNA cases. Next slide, please. In fact, in serology, a recent preprint of the Muller's group in Düsseldorf had compared different commercial tests against different targets, measuring different antibody subtypes. And the results show that although the nucleocapsid restricted test showed a better sensitivity, spike-based assays had a stronger correlation with neutralization capacity. Next slide, please. I also have depicted my DRAFAS, Santiago, Valor, for understanding the coronavirus disease path. That is the way also to understand how you should position and translate the results of the different tests. Initially, we used to have the disease onset as the only reference. We believe in the initial steps of the pandemic phase that the things were easy, and with this disease onset we have everything organized. We know right now that this is not true, and in fact we have symptomatic patients and pre-symptomatic and asymptomatic individuals. The thing is that we know now the infectivity in both cases. We know that the infectivity of symptomatic patients having the disease onset as a reference is approximately of -2 plus 5 days, so more or less 8 days. In the case of asymptomatic individuals, has been recently published that approximately we are handling plus 5.6 to up to 8 days. This is a small period of time that we have here. And we have two different situations. We have the situation where we only have results coming from the molecular test, from the PCR, and then we have other part where we have both, where we have results coming for the serological and the molecular part. In the initial part where we have not data coming from serology, what is very important is to understand that the value of CT, especially if it's low, can provide us of great help for direct our traces, our tracking teams to locate the places where the problems, the real problems with infection and with the different transmission chains are starting. So this is an important value that should be used properly in order to prioritize the activity of our colleagues looking for cases. On the other hand, we have the serology. The serology help us, as I said before, to support the molecular results. And now we know that serology that becomes positive, depending on the lymphopenic period after 14 days, is an important issue. And besides, we should know that the next slide, please. The next slide. Sorry. No. Oh, no. You have to go after this. Well, the thing is that now we know also that things are not easy, and Amiens University has recently pinpointed that asymptomatic carriers do not generate, at least in the same amount, neutralizing antibodies. So the longevity of the protection against reinfection is questionable. That's their own words. And next slide. And anyway, we should understand the time and the role of the different antibodies mediated response. Now we have more proper times for the activity of antibodies. We know that that the coverage of IgG at least reaches 273 days. And also we have the values of the IgM and IgA of approximately 100 days. So, of course, we know that the coronavirus antibody response is not a great thing, let's say, but it covers sufficient period of time to provide at least 4 important activities. Antibodies mediate neutralization, antibodies mediate phagocytosis, antibodies mediate cellular cytosity, and also complement deposition. Of course, we have to keep in mind that antibodies, they follow what is called the original antigenic thing, and it has been seen that neutralizing antibodies are influenced by the previous experience, so history of the patient is important. It is clear to keep in mind all the concepts and understand the situation and the need of this test, and understand the coronavirus, and understand that coronavirus is not just numbers. It's a large amount of individual cases. So it's important to focus our technologies in cases, and I think that is a wrong message to think in terms of pandemic just in numbers. Thank you very much.
Let me then introduce Dr. Philip Rosentuck from EUROIMMUN. I think for many of us, it's still a hot topic, the relevance of IgA in the immune response to the SARS-CoV-2 and its clinical value in the COVID-19 diagnostics. Please, Dr. Rosentuck.
Hello, Dr. Rosenstock, can you hear me? And underneath the screen on the right-hand side, there's like a little world where it should say English. So it says interpretation or Spanish. In the lower part of the screen, so you see, what do you see? The chat, share your screen, record, right? So all to the right.
Sorry, yeah, sorry.
No problem.
And now it should be in English. Sorry for that.
Wonderful, Dankeschön.
Okay, sorry. Okay, so one possible reason or one point that shows the relevance for IgA assay is the high neutralization capacity. That's just much higher than IgM testing. Okay, so what kind of forms do we have? We have a monomer and a dimerized form. And the dimer form is found in secretions as well as in serum, which is where we detect it. And it is released by mucosal surfaces. And here it represents a primary defense mechanisms against local infections. And well, we are talking about a respiratory infection here, which is why IgA has a special kind of function to mediate neutralization within mucosal surroundings. And its function is to prevent the passage to the circulatory system. And it is written in the quality standards for microbiological and infectiological diagnostics that antibodies of the subclass IgA have a significant role in certain infections. And well, it's not a new topic for SARS-CoV-2. IgA is quite often or frequently considered as being a marker, for example, for acute infections like Bordetella pertussis, Toxoplasma gondii. Also reinfections. Here we have several respiratory infections like Mycoplasma chlamydia, but it also plays a role in reactivations, for example, herpes viruses, and also in chronic infections. IgA is considered as a valuable marker. So what's now the benefit of IgA in SARS-CoV-2 questions? Well, to answer the benefit, we need to know the question first. So the diagnostic questions are always, was there a past infection, and did the patient develop antibodies? And the answer is here, well, we need a very high diagnostic sensitivity after the PCR phase to answer, well, to not let there be a diagnostic gap between PCR and serology. And here IgA is definitely valuable. And second one is protection. And of course, nobody is able to answer the question about protection. But it was shown that there's a very good correlation between IgA and the neutralization test. However, for detection of neutralization effects, we need to select an appropriate target for the IgA response. So, of course, we know that, or it is described that neutralization is mainly mediated by antibodies binding surface proteins. And well, considering the structure of SARS-CoV-2, the spike protein might be an appropriate tool because it is a surface protein rather than the nucleocapsid protein. And of course, spike protein is an appropriate target because it has a special kind of task for SARS-CoV-2, which is the receptor binding. So the spike protein contains the receptor binding domain that is then attaching to the human ACE2 receptor. This is why it is strongly believed that antibodies against the spike protein, especially here the S1, represent a neutralizing target. It was also described that the nucleoprotein might be insensitive in the field of diagnostics, and it is not indicating any neutralizing effect. So there was a recent publication also with involvement of Public Health England, and it was stated that a nucleocapsid-based protein should be confirmed with another test system. Okay, so I'd like to state some few presentation, some few publications, Hertz van Gessel stated that there is a good quantitative relationship between neutralizing titers and an IgA assay. And IgA is a useful addition to like the renowned serological markers. This was also stated by Lerner. They found a good correlate of protection between IgA and the neutralizing titer, and also Ogba showed that the commercial, the EUROIMMUN assay IgA showed a very strong correlation to a plaque reduction neutralization test. So when answering, when trying to answer the question of is there any protection, IgA might be a hot topic. Now also I've stated that that sensitivity might be a thing that is needed in order to close the diagnostic gap between positive PCR and serology. And we know that the majority of cases, the serology is going to be positive just a few days after positive PCR or the onset of symptoms. However, as you can see on the right-hand side, there are also isolated cases with a very delayed IgG response. And here, of course, the IgA response is to be shown as being, it was shown to be closing this diagnostic gap. Here you see a patient that was IgA positive just from the beginning, but who did not develop any relevant IgG response. And also here, the diagnostic relevance, I'd like to state some few publications here. Berkers et al. Stated that IgA was detectable earlier than IgG and IgM, and it has a greater sensitivity than other serological methods. Same was described by a Chinese working group, and here they stated that IgM antibodies were significantly lower in their sensitivity compared to IgA in both severe and non-severe patients, and they stated that enhanced IgA response was a kind of, let's say, that there was a link between enhanced IgA response and the severeness of infection. And this is why the authors hypothesized that the disease is in parts IgA mediated, which is why IgA might be an important target. However, there is certainly, or there was a disadvantage of IgA. This is again referring to our IgA assay. In this publication, a limited specificity of approximately 94% was described. And this was also what we found in internal analysis. However, we were recently able to improve specificity from 92% to now more than 98%. We have improved the formulation of our sample buffer. We have now an improved sample buffer, which increases the reliability of the IgA assay, so that this limitation is now circumvented. So in summary, this is my last slide. Serology should not be used to detect acute infections, neither IgM nor IgM. And IgA is a well-known marker that was described to be relevant for other respiratory infection. And the function of IgA is to neutralize pathogens, also majorly in the mucosal surrounding, which we definitely have here in SARS-CoV-2. And we need to detect IgA antibodies against functional surface proteins in order to answer some relevant question, for example, the question about neutralization capacity. And it was shown by several publications that IgA against S2 correlates very well with a plaque reduction neutralization assay, and that IgA has a high diagnostic sensitivity in SARS-CoV-2 testing, and that the low specificity of IgA was recently improved from EUROIMMUN by introducing a new assay format, a new assay buffer. So thank you very much for your attention. Thank you for being able to talk about the IgA testing, and I hope that I was able to answer some questions.
very much. Hello? Yes, thank you very much, Philip. Your talk is challenging, is new stuff coming, so we are very happy to have this type of information, and you have done very clearly and with a lot of message, new message. The questions we are going to delay for the last of the session, of this session. And let me now introduce to Dr. Mary Rogers. Dr. Mary Rogers is the principal scientific in Abbott Laboratories in Chicago, USA. And due to the recent great impact of the FDA emergency use of authorization of a near COVID-19 antigen test, and due to other Abbott serological tests that are in the pipeline of Abbott, we are very happy and anxious to have you here, Mary, and please, you can start whatever is convenient for you, and we are happy to have you here.
Thank you so much. It's a pleasure to be here. Of course, I wish I could be there in person, but here we are online. So I'm sharing my screen and hopefully, okay, good, we can see it. So my name is Dr. Mary Rogers, and I'm a principal scientist in Abbott's Infectious Disease Core Research Group. And I've had the honor of being a part of the assay development teams for many of the tests that I will be showing you today, as I talk a little bit more about the solutions we have for a spectrum of testing needs and settings. So, there we go. There we go. So as many of you know, Abbott has a strong legacy in infectious disease diagnostics. Our division was founded in 1971 with the first hepatitis B test, and we've continued to innovate and add new tests as new research became available about the new needs for the various hepatitis viruses and HIV, which are shown as example timelines here. And what I think is really useful to make note of is that the test that we put out in 1971 is certainly not the test that we're using today in 2020. And I think that as the information continues to evolve about SARS-CoV-2, we will continue to see evolutions in the diagnostic needs and the diagnostic solutions to meet those needs. So if we look back on that timeline, specifically to 1985, that was when Abbott had the first FDA-approved test for HIV. And I see some parallels between that time and where we are now with SARS-CoV-2, mostly in that the ability to stem the pandemic and identify active cases of people who are infected was key then as it is now, and diagnostics can play a really important role in reducing transmission. So we're all becoming familiar with the typical diagnostic marker profiles of viral infection and recovery. And this particular plot is a general plot. It's not specific to SARS-CoV-2, but it can basically be broken down into two main phases. The first being the acute phase, where we're looking at viral markers, and the second being the immune response as someone begins to recover. And so it's really exciting to see how, as we release new diagnostic tests, they serve the public, but they also are being used in research to now define the actual timelines of what days these tests are most likely to be positive in a typical infection. So for our molecular tests, we have a series of very highly sensitive tests on automated systems, the M2000 and the Alinity M. And these are high throughput and can be used in large reference labs and hospitals using a nasopharyngeal or oropharyngeal swab. And these are highly sensitive, down to approximately 100 copies per mil of virus. And as we are seeing these tests being used around the world, we're starting to now see literature showing how the actual curve looks for most patients, and that's shown here, where as we go over the course of an infection, we see a peak in viremia approximately around the time of symptom onset that then declines slowly over time over a matter of weeks. We know that most RT-PCR tests are sensitive to detect the majority of this curve for diagnostic purposes, but a number of papers are starting to emerge showing that the actual critical transmission window when most people are likely to transmit SARS-CoV-2 to others is actually between approximately 2 days before symptom onset all the way out to approximately 10 days after symptom onset. And if we look at the viral loads for patients in that window, these are the peak levels. This is where we have CT values well below 30. And part of the emerging evidence is starting to also show that the amount of virus that can be recovered as actually infectious in cell culture or actually shown to infect other people in transmission settings, the cutoff for when we can actually find infectious virus from a patient appears to be a CT of approximately 33, which also corresponds to approximately the limit of detection of an antigen test. Antigen tests have a lot of advantages, and Abbott has a PanBio rapid antigen test that allows us to detect infections on a massive scale because it has scalable manufacturing and does not require instrumentation to be able to use the test. We get the results very quickly from a nasopharyngeal swab. This is not high throughput. This is one at a time sampling, but we find that the sensitivity when samples are compared that have lower than a CT of 33 of 98.2%, meaning that we can catch most infections. This actually ends up being really key if we go back to this plot for these 2 days when people might not have symptoms yet. And it can also be important for when people are completely asymptomatic, and this could be completely silent if they're not reporting to a doctor's office to be tested. And so antigen tests could serve a really unique role in testing for that pre-symptomatic and asymptomatic phase as we try to return to opening society. So if we go back to our little timeline here and move towards the immune response or recovery phase of infection, we're looking at where IgM and IgG are detectable. So Abbott offers a variety of antibody tests, as we've been discussing, that meet a spectrum of testing needs. So the needs of a small lab might be very different than a reference lab that's going to need to process hundreds of samples at a time. And so with all of these different offerings, our blood tests are able to determine if someone has been infected in the past and has developed antibodies. And we have tests for IgG and IgM. These tests are also helping us to understand how the virus is spreading from an epidemiological standpoint as we're moving towards developing vaccines and treatments. So just to give you an idea of all the many different types of testing needs and testing solutions that we have, from the molecular to the serology side, we have tests that will be able to meet the needs of large-scale labs like reference labs, as well as first responders who really just need a test immediately and for one person at a time. Those would be more likely to use a lateral flow test, which we also offer. So I mentioned that we have IgG and IgM tests, and I'd like to speak a little bit more in detail about those on our automated platforms, Architect and Alinity. So the target of our IgM test is the spike protein. Generally, IgM antibodies have a lower affinity for their target, and we see the best performance for sensitivity and specificity for IgM using a spike protein target. Alternatively, we have the nucleocapsid target for our IgG test, where we have a high level of specificity by using the nucleocapsid, And as time goes on, and in the joyful day when we have a readily available vaccine, the only way to really differentiate between an infection that has occurred naturally versus an immune response to the vaccine will be to have a measure of nucleocapsid response by an IgG test versus a spike protein, which would be masked by any immune response that's developed due to a vaccine. So data is starting to emerge as people start to use these tests. An example is shown here from a study that came from UCSF, who we collaborate with. And we're seeing that in the same group of patients, whether we're looking at IgM or IgG, that we're seeing a similar trajectory where IgM and IgG levels rise concurrently around 1 to 2 weeks after symptom onset. And so there does seem to be, in most patients, IgM occurring first, but the difference in that window appears to be approximately 1 to 3 days before IgG starts to become detectable. And so you can see another depiction of that curve here when we look at clinical performance of the IgG test. You can see that as the number of days post-symptom onset increases, that we have an increase in the number of samples that are detected with the IgG test, where at 14 days post-symptom onset, we have 100% detection in this set of samples. We have excellent specificity, where our negative agreement is 99.63%. And we also have very good precision and percent agreement as a result. As we take a look at the IgM assay performance, we're seeing a similar trend, although we have more detection earlier on as people start developing IgM slightly earlier than IgG. What we're seeing here is that we actually have even better positive agreement if we categorize our samples based on the number of days post-PCR positive result as opposed to symptom onset. But a caveat being here that some people might get a PCR test several days or even weeks after that first symptom that they experience, especially with such a wide spectrum of symptoms that may not actually be critical early on in an infection. And so I strongly feel that the best way to measure the performance of a test is by dating from symptom onset, since that is something that is a little less subject to changes in healthcare and availability of healthcare for RNA testing. And so here again, we have a very specific test with our negative agreement at 99.56%. And again, good precision and percent positive agreement. So there are some benefits of having separate tests for IgG and IgM, and several of them are highlighted here. So the first one being that when you want to understand whether or not someone is in an acute phase versus more of a convalescent phase, knowing whether they're positive for IgG and IgM versus just one of those markers alone can help us with staging of whether someone is in an early or later phase of recovery. And that can be important also down here from an epidemiological standpoint, as we're trying to understand how long the virus may have been in a given community. We're also able to do the test at the same time. So we can, on our automated platforms, run IgG and IgM at the same time on these random access analyzers. So you get both results without any delay in between. And this also is particularly of importance when we're thinking about asymptomatic individuals who may not have had an RNA test because they didn't have any symptoms. And so an IgM and IgG antibody test can help us in particular with staging those unusual kinds of infections that might be otherwise kind of difficult to determine how recently someone has started to recover from an infection. Whereas these benefits would not be found with a total test that would not be able to differentiate between the different serological markers. And so these tests have continued to be used worldwide. At this point in the literature, in the scientific literature, there are more than 60,000 samples that have been tested and published in the scientific community. And so some of the highlights of the findings of those studies are that we're finding even better sensitivity for diagnosing SARS-CoV-2 infections if we use a combination of PCR and antibody testing. because there is that lower window of lower levels of RNA that could go missed by just an RNA test alone that an antibody test would then pick up because of that little window phase where people are starting to develop antibodies and reduce viral load. We're also obviously finding out that as we define those timelines, we're identifying what time after symptom onset makes sense to use each one of these particular tests as a marker. And the results from these studies are also informing healthcare policies. We're seeing good correlation between the antibody levels, even with a nucleocapsid test, to the levels that are corresponding for neutralizing antibodies in a patient. And this is also starting to show correlation to immunity. So far, we're not seeing cross-reactivity to other coronaviruses. And just to highlight a few of the studies that are included in that overview, in particular, Poland looked at cross-reactivity with other coronaviruses and did not find any cross-reactivity with our tests. So in the interest of time, I'll just focus on one of those studies, which came from the University of Washington, where they found even better metrics of sensitivity and specificity with over 1,000 samples than we have in our package insert even. And what really struck me in this figure from their paper was that there's a wide variety in immune responses that varies from patient to patient. Each patient is unique, and while some may develop antibodies within 3 days, some will take a full 2 weeks to develop their antibody response. And this is a reflection of the uniqueness of the human immune response in general. So where do we go from here? I've kind of walked you through where we came from March all the way up through August. And now here we are in September, looking at how we could even improve our tests or our access to tests even, as we're starting to look more at potential decentralized models and whether or not capillary or dry blood spot testing could be provide a good advantage for expanding the usefulness of these tests. We're also looking to understand how a quantitative test may be useful, especially in terms of vaccines in development and monitoring effectiveness of those vaccines. And then we're also exploring how a core lab or high throughput antigen test might serve a unique need in the SARS-CoV-2 pandemic today. And so with that, I'd like to thank you for your attention, and I'm looking forward to continuing the conversation.
Okay, so thank you very much for all this presentation. Unfortunately, I have been requested that not go into a debate or just question. We don't have any question for the audience now.